Welcome to the K in Clarity podcast. I'm the host, Mezue. During this episode, we're joined by Caroline Pardo, founder of Table Talk on Health. Caroline Pardo has been instrumental in advancing evidence-based healthcare professional education and implementation science within the continuing professional development and medical education space. As a thought leader in human-centered healthcare interventions, she has specialized in applying clinical, social science, and research methodology to design, execute, and evaluate comprehensive education, training, and implementation science initiatives that meaningfully improve patient outcomes. Pardo's expertise in data-driven needs assessment, gap analysis, and strategic planning has enabled her to drive significant improvements in healthcare quality and clinical practice. Her leadership roles at organizations like Clinical Education Alliance, Platform Q Health, Genentech, and Medscape have positioned her as a recognized expert in bridging the gap between emerging clinical evidence and its practical uptake by healthcare professionals. Through her work on advisory boards such as Euron's AI-powered simulation learning platform, managed care organizations, and payers, she continues to develop compliant interventions that improve evidence-based decision-making and clinical practice. In this conversation, we discuss her extensive background in sociology and healthcare, emphasizing the importance of education, communication, and patient advocacy in improving healthcare systems. And she shares her insights on influential figures in health advocacy, the role of social networks, and the challenges faced by healthcare professionals. Caroline also highlights her initiative, Table Talk on Health, aimed at empowering patients to engage more effectively with their healthcare providers. If this is your first time tuning in, here's the gist. The healthcare industry is buzzing with innovations, but there's a lot of noise and misconceptions out there. That's where we come in. Because of my experience in the healthcare ecosystem, I've gained a unique vantage point into the industry's inner workings. We're bringing you the conversations that typically happen behind boardrooms and strategy sessions, the real challenges, innovative solutions, and game-changing insights that are reshaping healthcare as we know it. On this podcast, we're bringing you face-to-face with the industry's leading healthcare founders, executives, and innovators. We're talking about the nitty-gritty of building and scaling healthcare companies, the hurdles they've overcome, and the strategies that have led to their success. More importantly, we dive into the personal challenges that come with trying to change a system as complex as U.S. healthcare. So whether you're a healthcare entrepreneur, a medical professional, or just someone passionate about the future of healthcare, this podcast is your backstage pass to the minds shaping the industry. Now let's have Caroline tell us a little bit about themselves. Welcome, Caroline, to the K in Clarity podcast. For the people listening, can you give a brief overview of who you are and what it is you do?
Absolutely, and thank you for inviting me to be here today. So I'm Dr. Caroline Pardo, and I am co-owner and principal within Integrated Action Science. By training, I'm also a medical sociologist and a gerontologist, and I serve on the advisory board for a number of organizations.
Wonderful. What you might know is we usually like to do an icebreaker here before we dive into everything. And so my first question for you is if you could have, a round table talk with, three individuals who you think are very special and, are involved in health, who would they be? What are their thoughts around health? What type of discussion would you have? And we can go from there.
Absolutely. I love this question, and I know that you know that I talk about table talks, so I like this question because I ask this question of other people. So because you said the focus should be on health or healthcare, I'm going to name three people who I think would have a robust discussion at a table. The first is someone that I admire being a female, and that is Clara Barton, who had the gumption to form the Red Cross. And to be able to do that, she traveled far and wide to share the story of advocacy for the needs of patients, the needs of people in the U.S. and abroad. And I think she would be a brilliant voice. Secondly, I think Jonas Salk. He, of course, was the person who led the research on the polio vaccine. And here's where I think I want to hear from him. This jab, or however that it was administered for the very first patients, you had to convince a whole lot of people that this was good for them. And that is still what we're trying to do in healthcare in so many ways. And I'd love to hear more about his thoughts on that, because he was truly pioneering at the time. And the third is someone from my training that maybe not everybody's heard about, and this is Pierre Bourdieu. And so Pierre Bourdieu is a French sociologist, and his whole body of work focuses on the habitus, or the power of structures to structure our thinking, and with our thinking, our choices. And I think that matters in healthcare. He also had radical ideas about how to break through that. And I think very often we need to take those kinds of radical approaches when we think about where we have healthcare issues that are stubborn or sticky, and we just continue to have disparities or lack of access or other aspects where folks just don't get the healthcare they need. So I think those three folks are all radical thinkers, and they have been meaningful in history, and I just want to hear them talk. I don't necessarily even need to be in the conversation. I just want to hear what they might say.
No, that's great. To start it off there, obviously, you've had a rich background in sociology and gerontology. How has that really influenced you personally, and what has been your approach, to these fields and your experiences in them?
Yeah. So one of the most impactful moments of my life, and I've told him this, was that I was completing my bachelor's study, and I was literally under a street lamp crossing a street, just on campus. And my professor, who was the dean of my department at the time, said, "Have you ever thought about checking out the sociology department for graduate studies?" And I went, "I don't even know what that is. I've never had a sociology class in my life." And I was going to graduate school, but not in sociology, obviously. So I had a free hour. I actually walked across the street, found the office, found the dean, directed me to a faculty member who was in the office, and he became ultimately my dissertation chair. No joke. And so why did this professor say this to me? Because he saw that when I was thinking about subjects and I was talking about subjects, I was thinking about the social lens or the social network that shapes the way that people think and the ways that whole groups of people can get things done. So when I approach education, which has been the space that I've been in, particularly continuing professional development in healthcare, I take that lens. So what do we need to think about how whole groups of people see issues or see challenges or see opportunities, and how can we take that learning and be able to apply that to improve the educational experience? Now, I think my training as a gerontologist is incredibly critical, because as a gerontologist, we're thinking about the physical, thinking about the psychological and social, and we're thinking about the structure of policy and the structure of payment models and all of those aspects that contribute to healthy aging or not healthy aging. And so I think like a sociologist when I think like a gerontologist, but because of my training, I had the opportunity to work in the hospital, had the opportunity to work in the clinic, and that has been so fundamental to the way that I now see education, because very often I think back to all those folks, nurses, doctors, etc., who were in grand rounds with me. What made a program great? What didn't? And I think about all of those RSS and other activities that my clinician peers saw and experienced. Was it really helping them improve their ability to help patients and improve outcomes? And so fundamental to the way that I even see the world today.
I know you spoke on the education component, also focusing on sociology. How do you think about, the access to care and how that approach kind of ties together the human side of medicine?
I so appreciate this. Became a sociologist again because I was probably already thinking that way, but what that training opened my eyes to were the social constructs, and that's led by policy, that's led by the way that people think about their own health, but then the way that people think about others, that embed structures in the way that folks engage with healthcare. That probably was a little confusing, but where I'm going is the following. Access to care is complex, and it's not just an issue of insurance, and it's not just an issue of money. Who has insurance and how coverage generally is determines so much of what people have access to care. That goes without saying. We know that. But why in so many cases is coverage tied to one's employment, or better coverage tied to employment? Are we then reproducing poor access to care by having those structures? And I know it's complex, and I know it's hard, and I know that nothing's free. So these are really tough questions. But that's what has helped me think through when I'm looking at a project that's focused on improving access to care, improving outcomes generally, reducing barriers to care, and reducing disparities in care. We have to look at not just how an individual walks through the system, but how the system is structured for those individuals. And when I'm looking at education, or I'm planning education, I have to take that in consideration. And I'll give you one quick example. We can educate, or we can have education that works perfectly. Rarely is that true, but it can work perfectly, and make sure that every single nurse or doctor or NP or PA that goes through the program knows exactly what to do. But if they can't do it because of a system issue, they can't prescribe something, they can't run this test, they can't see this patient or refer this patient because of a structural issue, our education has not met its aim. They've learned, now they're probably, quite frankly, frustrated because they can't do the thing they know is best. So how do we fix the whole system? One individual can't, two people can't, but a whole group of folks who are minded to that can solve these issues.
I know, tying back to, education barriers and how systems are structured, I know part of the conversation that we had earlier, can you share your early experience in grad school, and also focusing on, the focus of food and nutrition? I thought that was an interesting thing that could, mention and talk about how systems are connected.
Absolutely. So I did have the pleasure of being able to work in the clinic, and I got to engage with patients who had food and eating issues, including those, and particularly those, this is a big area of focus, those who were in the oncology clinic, because nutrition is a big part of wellness for those who are in dealing with something related to an oncology state. And then I also work with those folks in the community who had poor access to food. So right now I'll just share an example that we talked about from an oncology project that I worked on. I'm always open to talking about Meals on Wheels and some of the work that we did in the community there. But this story, I think, showcases some of the disconnect that patients have with clinicians that go hidden. Driven so much of my patient work focus. I'm just seeing, this is one example, but so many of these. In an oncology project, we were examining the role of food and eating, and the role of nursing and clinician conversations with patients in the clinic to ensure that food and eating was a priority for discussion within the treatment paradigm or the treatment pathway for these patients. It's already very difficult very often for patients to get past some of their symptoms that may include nausea, it may include diarrhea, it may include these other things that make food and eating kind of difficult. So what was being done prophylactically in the clinic to help them? And one of the things that we discussed was, hey, we need to learn from patients. What are they saying? So yes, of course, we talked to the clinicians. We also talked to a bunch of patients. And one story that resonates with me was there was a beautiful woman who was undergoing breast cancer, I think it was metastatic, and she had a long journey in this. And she had rapidly lost quite a bit of weight. Now, a patient who's in cancer treatment who rapidly loses weight, it's not necessarily a good thing. And very often it's a very poor thing because there are many risks that come from that. When she went to see her friends, they all remarked how beautiful she looked. She looked amazing. And she had struggled with weight her whole life. And she really liked these compliments. So she didn't want to tell her physician that this was a problem. She didn't want to talk about food and eating. She really liked her compliments that she was getting. And so when she talked to me, I'm not the doctor, I'm not the nurse, I'm just a person who's giving them my ear to listen and understand their experience. She said, shh, don't tell my doctor. But I really don't want to address the fact that I'm not eating much and that I'm losing a lot of weight so fast. My husband's worried, but I think I look really good and my friends keep complimenting me. So I'm just going to keep on this path. And it was something that really needed to be addressed. And that was just one, that's a simple experience. There were so many of these examples that doctors and nurses and the patients were not necessarily talking about things that really did matter because they seemed simple, or they seemed like, oh, we should be talking about that because why wouldn't we? Or they seemed like somebody else was already talking about it. And those are the issues where when I'm thinking about a patient perspective, what if, going back to that example, a nurse or a physician had talked with this patient and said, do you know how important food and eating is? These are the risks that you have when you're not doing that well. How can we meet your goals while we also ensure that you have a healthy path forward? Because when you're in this treatment that's so serious, you need to ensure that you have adequate nutrients. Let's talk about it. Super critical for this patient, and she was really heading down a poor path. And I think that's just one example of whose accountability is it to talk to the patient about these kinds of things in the clinic. Very often it's not necessarily clear.
I was going to say, why do you think these blind spots happen? My own personal take might be, just from what I've heard, is maybe it comes down to education, right, of how doctors have, grown up and what they're taught to say. And then additionally, I would also say it's potentially doctors, they're worried about time and how much time they can spend on each patient, right? So they maybe want to focus on what they deem as the most efficient of issues. Mm-hmm. What do you see are, the potential blind spots and why these occur?
Yeah, I think there's a whole rich body of research on this. A couple of things that I've seen and a couple of takeaways I've had from just being in the space. One, you're right. Nurses, whoever is seeing, or NPs, PAs, whoever is seeing a patient, they have very limited time. And that's just the way that our system is built right now. So how can we still work within that, knowing that that is a constraint? But two, what's happening is, again, whose accountability is it? So when I spoke with the physician for this patient, for example, he said, we talk about it all the time. How do you talk about it? When I'm leaving the visit, I say, do you have any questions? If she really wanted to talk about it, that's her opportunity. And I actually read something just last week that challenged that thinking, that that's not the best way to ask a question. So I'll throw this at you. Do you like to ask a question and then feel really dumb about what might come back, or have your question feel dumb? Probably not. So when a physician, particularly someone who we might feel holds the power in a relationship, particularly if you're sitting in a paper gown at a table, you probably don't feel like the most powerful person in the room, says, do you have any questions? You just might feel really vulnerable and don't want to ask those questions, or a question at that point. But what if that were flipped with, I know I've shared a lot of information today, and I know that there's a lot that's happening outside of this room that's impacting you. What else do we need to talk about today that could help address any of the things that still might be unclear to you or might be going on that we haven't touched? It's a little bit longer setup, but you're probably going to get a real point, probably going to get a real response. Some wording like that could be so critical. But why don't we do that? Because, again, we're so stressed in time. What if they have something really important that we need to now address that takes another 20 minutes? And that's the dilemma that is happening in clinicians' offices so often. So how do we equip patients and clinicians to be able to share information? Maybe it doesn't have to all happen in that one room. Maybe there are ways that we can share information before the visit, during the visit, after the visit, between visits. We have so much digital tech. There's so many wearables and tools that folks have. But those folks that don't have that, what else could we do to ensure that those things that really matter to the patient are brought out in that room? And we might have to be creative in various circumstances, but it's super critical that we do it. But again, time is a constraint. The dynamic that is kind of built is a constraint, but then maybe us just not using all the tools that we could use perpetuates that constraint.
I know we've spoken, about kind of your experience on healthcare education as well. I think something I want to note is, you've also had a background in pharma. I want to tie, how do these experiences, shape, your approach to the healthcare journey, and as well as when it comes down to healthcare literacy? I think this one example you mentioned kind of speaks on that, but how does that kind of go together?
Well, that's such a big question. So I did have the opportunity to work within medical education strategy and funding mechanisms for independent medical education within a pharmaceutical life science organization. And I love that because what I had the opportunity to do was truly explore what the need was across the U.S. for clinicians related to a very specific therapeutic area, in my case, a few therapeutic areas, and make decisions to fund medical education initiatives to close those gaps. That's incredibly exciting. But what I also saw was that there's never enough money to do everything that needs to be done. So we had to make really careful decisions. Following that, I have been in the chair of it as a role, various roles in companies that develop that education. So I'm not just funding it, but I'm actually delivering it. So designing it, delivering it, and trying to make good education. From these various roles, what I've seen is we have such an opportunity as an education professional. So here I'm specifically talking about medical education or continuing medical education. So the education doctors, nurses, nurse practitioners, physician associates, pharmacists, but allied health as well, med assistants and med techs. How do we help equip them to do the work that they need to do? And so often we think, oh, there's a new therapy, so there needs to be education so they know all about that new therapy. But yes, that's true. But again, it goes back to the point we were talking about earlier. If that therapy, everybody knows everything about it, but they can't implement it because they need to do a test first, or they need to think about where the patient is in their process of care, maybe have some pre-education with the patient to help them make a good decision. So many constraints about how we learn to do something, but then have barriers that have to be overcome to actually implement what we learn. So what's been exciting to me is as I've evolved in my career and then paying attention, but learning from my peers and learning from the folks who develop education, is that we have to think well beyond what just people know. They need to know what to do, how to do it. They need to very often know how to bust through barriers that keep them from doing those things. And then we often have to think about what does a system, like a clinic, a practice, a hospital, need to know or do differently so that folks can actually do that work. And I'll give you just one quick example. Many years ago, I was working on an education plan for a new product, and it was a drug that went through a wrist rather than having to go through the groin, made things a little easy. It was actually a device that made things a little bit easier, but it just wasn't getting uptake. It was safer, it was quicker, required a little bit less staff. I was working in other countries. Other countries were seeing an uptake of like 94% in the U.S., well below a quarter, early on. What's happening? And when we really explored this, what we found was that in the clinics where this particular device was being used, if the head clinician didn't like it, nobody did it. The juniors didn't feel that they were comfortable trying it, or they didn't get the ability to practice, or because it required a nurse to help them, the nurses didn't know what to do because they had not gotten trained. So we could have had all kinds of training to those individuals on how to do it, but if the structure never let them try it, it's never going to work. So what did we have to do? We had to recalibrate. Is it the heads of these departments that need to understand, look, this is going to be safer, this is ultimately going to be quicker, this is going to use less staff. Let's show you how we can transform your whole team and your processes and your workflow to be able to accommodate this new thing. When that occurs, then folks will actually adopt it. So education can't just be in this vacuum. It has to be planned around and based on knowledge of the context of care and how things are actually happening. And I think that's exciting because then every single research project becomes like a little puzzle. Like, do we really know what's needed? Do we know what's needed by everybody? Do we know what's needed to put this education in this system? Well, if we don't, let's ask some better questions before we just go to the drawing board and start mapping out learning objectives. So I have learned to be intellectually humble in this career, and that's kind of fun.
Yeah, it's a good thing. I think a good thing that keeps you humble is conversations and learning through others. And I know Table Talk on Health really brings patients and health coaches together What made you want to start that initiative?
Yeah, so Table Talk on Health is a communication company that's focused on bringing patients, very often with lived experience, but also health coaches or patient community leaders or even just patient advocates from various walks of life. And I don't mean just patient advocates from various walks of life together to share stories of a journey toward health and wellness or a journey through illness and disease. And the original ethos for this was established to do the following, or based on the following: wanting to equip patients to be able to talk with their clinicians or their caregiver team in the same way that they have comfort talking with their friends and their family over coffee, hence the name Table Talk. But the idea was too, so by the way, our logo is a coffee cup, so to carry that all the way through. But the idea was too, when we're on an exam table, again, going back to that example I shared earlier, we might feel very vulnerable. I know even as a patient myself, all my best intentions and questions probably escape my head. One, I'm sitting in a paper gown. I'm probably a little nervous. I'm processing information. It can be really scary. How do we equip patients to show up and ask good questions and feel comfortable and confident in that encounter? And so that's where it was born. So I had some really great discussions lately, and I'm looking forward to dropping a whole library of new content. We've talked about palliative care and what it means to be facing really tough questions. We've talked about clinical trials and how to be one's own advocate. Some of the folks that we've had on recent episodes have helped walk me through their experience of having a husband, for example, who was diagnosed but actually was kind of not sure what was happening, and the wife said, "Oh no, we have to go have this checked out." And then suddenly she's thrust in this place of, I either learn fast or we don't move forward. So she said, "How do I learn fast?" And she found a community, a patient community, to help her do that. So, and then health coaches, just walking through what it means to think about health and wellness differently. And one of the most unanticipated but amazing people that I've spoken to recently, she works in ensuring that folks have access to health insurance and health plans that support them as they're aging. Interesting, lots of folks maybe do that. Her focus is on just busting down barriers that perpetuate disparities. And so she has a project called the AI Trust Journal that helps patients and others be aware that information that may come through artificial intelligence may be perpetuating biases and challenges patients to think differently. So it has been an exploration, and I've loved all of these conversations.
Tying that together, right? I know your research and programming has kind of focused on particular theories in, social networking theory and education theory and healthcare. I guess, how do you think these theories are going to really affect and work in patient and professional education as well?
I love this question. So one of the people that is so revered, or professionals that are so revered in the continuing professional development space, particularly related to healthcare, so education for CME and CE for healthcare professionals, is the work by Don Moore. And so Don Moore is obviously very well respected. He and colleagues, Green, Gallus, and others, took some approaches to measuring the impact of education and remodeled it and helped us think about a framework for planning and measuring to ensure that education is really effective. And it's our language within the CME space. And he has continued to say that we need to evolve with the times. We need to make sure that we're keeping education and our planning and measurement live and vibrant and reflective of the current times. I have had the privilege, particularly over the last year, to really dig into the work of Dr. Kevin Volpe, who's a behavior scientist, and Dr. Damon Centola, who is a sociologist as well, and actually working on a paper with them has been, we'll see where that goes. I'm hopeful that we can get that out. They're brilliant. I've just learned from them and just soaking in the opportunity to do so. And they've helped me see through them and others that when we just think about the very same issue that we talked about earlier, that an individual clinician can learn what to do, how to do it, have the skills, But if we don't think about what it takes to apply that in practice, we're still leaving them a little short. And so the work of Centola, the work of Volpe and others have helped us see, many others in this space, I'm not saying they're the only ones, that there are ways that we can improve a clinician's confidence that they can do something. And with confidence, then that their motivation and their intention and then their action in practice is improved. And one of the ways that we can do that, for example, is helping them see how their peers are doing things. One, if we are showing clinicians how their peers are taking in information and then applying that, they're probably getting really practical guidance to bust through some of those barriers. They're feeling more confident that others are doing this and learning from the way that they're doing these things. And they're gaining some, again, those practical kind of tools to be able to apply in practice. When we pull together then this great education, learning science that Moore and others have helped us evolve, and then network science that helps us see the power of the network, right? How peers are doing things and how they're busting through those barriers and challenges. And then we're layering in other types of social science so that we're showing how very practically things can be moved, like those challenges with structure and access. Then we are equipping healthcare professionals to know what to do, how to do it, feel confident about making change, and then have practical tools and approaches and strategies to be able to implement those things. So then we're equipping not just individuals, but whole teams of clinicians to be able to improve practice. And through all of this, and it's so critical, it probably was not where I was when I was first in this space, but it is where I am now, measuring the impact of everything we do at the patient level. Great, people learned something. Did it improve outcomes? Great, they learned how to do something. Patient outcomes actually improved, and keeping my eye there. And there have been some great leaders in our space who've really pushed me to think that way. That's also how I think our industry is growing and evolving, and it's such an exciting time to be a part of it.
No, I think having the focus on patient outcomes is essential. You want to see how it can produce the best results and really solve problems and provide those great solutions. So I love that you're focusing on that. Switching gears, but on a similar track, is I know you've had, a lot of focus in consulting in healthcare. And I wanted to see, what do you think are the common bottlenecks that happen in healthcare organizations, and how do you really help teams overcome them and those challenges that they face there?
Yeah, I am just one human in such a big ecosystem, and I appreciate the question. I'll tell you what I've seen, and I'm continuing to learn and to learn from others. Very often, and I think you and I may have chatted about this, when we look at problems, we think about what are some common categories of drivers of gap or variation in care, and evidence is often one of them. Like, do people really know what to do? Is it clear? Financial incentives can often be misaligned. So folks very often do what they're incentivized to do. So if they're misaligned, that can be a problem. For example, I believe the data point this out, but it's still uneven. But when the copay for a primary care visit for a wellness check was removed or reduced based on policy, folks got them more often. And so that's a financial incentive solution to a barrier that existed, because it's not necessarily convenient to go see your doctor for an annual checkup. Preference sensitive decision making remains a barrier. So some folks have really strong ideas about health. Of course, it's very personal. So, but sometimes those perspectives don't necessarily align to evidence or what we know is best evidence. So how do we help individuals learn about what the evidence actually shows? That can be a barrier. The biggest one I see, and this is what you ask, is systems and process. But that's the biggest problem everywhere in almost every industry, but it's systems and process. When it takes somebody to make 6 phone calls to set up an appointment, they may give up. If a system is so complex that between the time of a diagnosis and a test to affirm the correct route of therapy is 6 weeks, that's very frustrating, and it's not conducive to optimal outcomes. Those are just 2 examples. It can be as simple as I need to, as an adult, because this often happens in pediatric care, but it doesn't happen in adult care, go to 6 different clinicians for one issue just to get, and then I serve as the communicator between all of them. So that coordination of care is hard. It's very hard. And so does the patient have what they need to do that, the time to do that? It's very expensive to take off work, do the things, go to the appointments, pay all the co-pays, and then still serve as the primary communicator. Like, that's hard, and it's frustrating if you're not feeling well, or you're not well, or you're feeling stressed. It's really hard. So systems of process are a primary gap. So anytime that we can solve for that by asking the question, is there a way that we can make this part of this easier or streamline this communication? And it could be as simple as, do we give a patient, or do we offer a patient education right after they hear bad news? Is that the best time? Probably not. They're probably, their minds are spinning, they're swirling, they're having to reconcile what they just heard. Probably not the best time to put them in a room and have them go through all their treatment options. But that happens. So how can we just think through those different situations from a patient perspective? And if we have the capacity to change it, sometimes we don't, but if we have the capacity to improve that, to help patients and to help the patient journey and experience and to improve outcomes, let's do that thing. And so that's a core area where we could make improvement. And because it's so hard to identify who's accountable for that, who can do that, who can make that decision, it gets tough sometimes.
Speaking of improvement, how's your executive level career development really came about, and what impact has it really had in healthcare on speaking on the successes of everything that you've done?
Well, first, I'm just honored by that. I have learned from every single team I've been a part of. I have also been very fortunate to be within teams and have the opportunity to lead various aspects of those teams, including leading people, leading strategy, leading functions. And I'm going to say this, while I've learned many things, I've become very humble about those things too. So humbleness has been a theory or a theme here now twice. I've learned ever more that team is everything, and a team functions optimally when every single person in that team is included and incorporated, and we're equipping them to work optimally for their skill set and their priorities. And while I've been very fortunate to lead strategy, there is a saying that culture eats strategy for breakfast. I actually think strategy is not separate from culture ever. Culture is what drives a business. And therefore, culture doesn't exist in this separate little space. Culture's your team. And when we support people, we support a business. And so my common theme across each of these experiences, but then also I would say to your point, what has been central to my focus and my growth, it's learning that, sometimes easily and sometimes through the hard way. But team matters and people matter, and supporting people is never a bad investment. And what I'm so happy about now is that when I go to meetings in our industry, or I go to convenings in our space, and I see folks that I worked with 10 years ago and 15 years ago, I know things about them, and we reconnect and we meet on a human-to-human level. And I want to do more of that, and to support people and build them up, and to just be a connector and to help people grow their own capacity. If I help them grow, everything I touch will grow too.
That's some beautiful words. What has been, some of your favorite experiences in healthcare, and maybe what are some lessons that you've learned that you think, other leaders can take from them?
I'm first going to say that I'm not sure that I'm still a student. I would ask that very same question to other people, I think, in my own space. I think a couple of things maybe I'll offer here. I understand now that I don't need to show up in every room with everything to say. I need to ask really great questions. That if I ask really good questions, or just show up with some curiosity, the conversation will move in a way that generally points to a good solution. And having a heart, but also intent to build a space for safe conversation is critical. Because if folks feel that their voice matters, they will speak. And when they speak, we get stronger. So I think I'm addressing your question, but that would be what I would say has been a core theme, but also my recommendation to others. I no longer aim to show up and be the smartest person. I actually think that's a pretty sad room. I want to show up and learn from everybody there.
Yeah, I think that's something that, I found in my life, right? If you ask the right questions with the right type of fervor and passion, it can lead to very introspective and interesting thoughts.
Absolutely.
And so I think that's a great thing that you touched upon. I guess I want to tie that together as well on how do you think that ties to that point and the point you mentioned on team, right? Asking the right questions, but also bring the right people together to really bring about the right solutions. Maybe you have some thoughts there.
People are people. There's no perfect people. Certainly not one of them. So I'm going to go back to I think the theme we were talking about earlier about finding solutions. To find a solution to address particularly a really hairy problem, but even something that might just be as like, what do we need to focus on this quarter? We need to make sure that we're asking a question about what are we really trying to solve for before we just throw out great ideas. And I still do this poorly sometimes, particularly at home. I'll throw out my ideas really fast and think everybody needs to react to them. But if we're aiming to guide a team or guide a strategy or guide an organization, pausing to say, what are we really solving for? Because we can find efficient ways to do lots of things. But if we haven't stopped to ask, is that the thing we really need to be doing? We haven't really solved the right problem. So I would say the thing I've learned, again, the hard way too often, and the thing that I'm continuing to hone as I move forward is making sure that I'm solving the right problem. And I can only get there by asking good questions. So what does a team need to do? Let's just make sure that, and let's draw out the collective wisdom within the team. Are we solving for the right problem? What is the thing that we really need to address? And it rarely the loudest person in the room going to have an answer to that question correctly every single time. So let's make sure that we're bringing all the voices in, because they're collective wisdom that doesn't necessarily just show up in the same way, right? So the power of having a team is ensuring that all the voices are heard. And that sometimes takes a lot of effort on the leader's part, because they need to make sure that they are creating a space and a share of voice opportunity for everyone at the table.
Perfect. I know you mentioned, things are moving fast, and I would say that's the same for, digital, tools and technologies. And so I think, what do you think is most important, in building tools, for healthcare professionals like clinicians, nurses and pharmacists? What are the key things to hone on to make sure that you're, providing the right solution for these people?
Mm-hmm. There are so many shiny things out right now. When I look at everything that's Gen AI or AI leaning or generated or has that component, I get excited too, right? Like I can go down a rabbit hole really hard on looking at new technology, trying it out, testing it. And I think your question is, what do we need to think about when we're thinking about healthcare professionals? At the end of the day, healthcare professionals are really intentional humans who have chosen to go into a healthcare profession, hopefully, ideally, because they want to help patients. How do we help them do that? Do they need another thing they have to log into? Do they need to just get the biggest tech, the newest tech because it's tech? No. They need safe, evidence-based ways to access the information they need for the patient that's in front of them. So it goes right back to how do we think about new tech? Flash is rarely the right approach, but instead looking at, does it really address the problem that we have to solve? And I am not a Luddite. I am not saying, oh no, there's no tech. There's so many great tools out there, and I'm trying them. I'm trying lots of AI tools right now. And with all of it, I know that I can't just jump in and say this is going to solve every single problem that we have. For example, we all know this. It's incumbent upon us to take the right actions here. When we're using an AI tool, we have to ask good questions. We have to test those things. We have to validate. We have to verify. And we can't remove the human element. Are we doing those things as we're trying out new tools? Does a new tool, here's another good question, fit within the actual experience of a patient in care or a clinician in workflow? I've seen this happen so often that a great new idea comes, but it comes from a developer or it comes from somebody who has a tech mindset, and then they layer it on top of like an EHR or electronic health record system, and it becomes like this thing that just is difficult to use, and it pings, and we take all kinds of steps to ignore it. It didn't help anything, even though it was well intended, because it actually created more work on the side of the clinician, or became annoying, or actually distracted from the process of care. So we have to think about, where does that tech actually fit within the process of care, and is it solving for a real problem? And then, is it actually getting the solution we need? So again, if it's an AI-generated solution, where so many advances are happening and so many exciting things are happening, and we still need to be really thoughtful about, how do I validate this? How do I make sure that this is really good information coming out of this? So I'm seeing some cool work and bringing evidence to the field, and I'm trying lots of things. Nothing's perfect. But I think if we keep the end user in mind and the workflow of care, so that it fits in and doesn't add burden.
I know you mentioned the patient. So how do you, do what you're saying as well, but, thinking about co-design with patients?
I love this question. And so I'm thinking about tech, but I'm also thinking about education. If an educational program is designed to meet the needs of patients, shouldn't we bring a patient in to get their perspective, or more than one patient, to get their perspective on what they actually need to hear or do or see? And we don't do that enough. If we're developing something for a patient to use, well, patients are people. There's not one patient that looks like another patient, because again, patients are people. We're all patients. So how do we ensure that we're actually helping the end user? And we have to do that with them. And I don't think it's developing it and getting it all the way to the end and saying, what do you think? I think it's from the very beginning, what do you need to actually help you do your work? I was actually involved with an organization that shared this story with me. I was not involved in this project, but a very large, well-intentioned life sciences organization built a patient tool. And that's not easy. I've been in the app development space. I don't know anything about it. I'm just working with a team, and I can tell you there's many, many steps. And they built this tool. It looked great. It's beautiful. And they got all the way to the end, and then they tested it with a patient group. And they were like, yeah, that's not actually something I would use, because it doesn't do these things. Well, then there's a lot of rework and delay. And we've delayed getting something good to help patients because they realized too late in the process. What if we just reverse that? I know it sounds so simple, but it doesn't happen.
We kind of talked about, the creation or co-creation and design. What do you think the implementation, really looks like between, healthcare professionals and patients as well on this?
Yeah, so that's the space that I've been working in for over 10 years through quality improvement or healthcare improvement or implementation science projects. And it's so critical. And yet it can be resource intensive work, like quality improvement, healthcare improvement work. But when it's done well, it is translatable and sustainable. So you're helping patients over time. You're helping greater numbers of patients because the work is translatable and critical work. I have seen lab value changes from simple process changes. That's huge. So by being able to move, for example, because I'm an education proponent, I'm always going to think this is a great solution, but I recognize it needs to be done at the right time in the right place. But as soon as a patient understands that they have a certain lab value that might indicate they need to do something differently, is that the place for education, for example? So you can help them see the consequences if they don't, help them make an informed decision, help them understand what they need to do differently, rather than just send them saying, 3 months from now, we'll check this again and see if we need to do something. Because patients very often will do amazing things to create a different outcome for themselves. So could adding, for example, an education component right up front, well, who's doing that? How's it done? How's it paid for? Those are all really relevant questions. What if a simple solution is found, a system does it, and they see patients come back and retest 90 days later, and look, we're seeing improvement in 20% of them. That's huge. But should that system keep that? No, ideally, that is a scaled solution. They make the world aware of it. It's someone helps them do that maybe, because that's hard for one clinic to do. But ultimately, that solution is shared with others who might have a very similar patient population or workflow or system size, and they can do that too. Then we're actually in the space of helping patients at scale through translatable approaches. And that's a rich space to be in. So that's what I get very excited about, is when we can combine solutions like workflow and education together, find something that works, and then make sure that it gets spread through other clinics and other spaces.
Education has been, a recurring theme for us. I guess, what do you think and what are your thoughts on, ensuring a high standard and quality of care through education for patients and, professionals alike?
I don't know that there's anybody that would argue that education's not helpful. Well, I guess I'll answer that this way. We do have the American medical school system is amazing. We create world-class doctors, nurses, NPs, PAs, and pharmacists and others, ensuring that we have a robust plan and approach and tools for continuing education so that that the 40 years that they'll practice are as effective in keeping those clinicians up to date and practicing optimal medicine, evidence-based medicine, timely state-of-the-art medicine is so critical. And so continuing education is where my passion is, and I think it's incredibly important. For that, we need to ensure that we're also equipping them to understand policy changes, and policy includes reimbursement because that drives so many actions. How are we helping ensure that all the clinicians that are touching the healthcare system have this really rich, practically valuable and relevant continuing education experience? So I think that's key for us, ensuring that we're continuing to ensure that our patients are experiencing world-class care.
Before we go on to the lightning round, this will be my last question for you. I think with everything that we've kind of discussed, looking ahead, what are some maybe innovations or technologies that you think are really going to contribute to having a more human-centered and equitable, healthcare system?
So let's talk about human-centered first. I think some of the work, I just came back from ASCO a few weeks ago, so that's the major meeting for oncology professionals. Huge meeting, so exciting. Personalized medicine is such an exciting space. To think that we can now see through very specific testing what the patterns and the needs of patients to address their very specific cancer type is so exciting. To be able to offer gene editing and gene edited solutions, incredibly exciting. So that's awesome. Being able to see problems or see disease paths well before we previously could through new diagnostics, incredibly exciting. And yet, with all of those advancements, we continue to have disparities and perhaps even growing disparities. So with those great advancements comes obligation to ensure that we're doing something policy-wise, structurally, socially, environmentally, to be able to close those gaps or at least narrow those gaps that are built by having unequal access, and unequal access not just to care, but to all the things that contribute to wellness. And that includes food and exercise and knowledge. And so how do we continue to close those gaps or address those? I do not have those solutions. But those are big questions that I'll continue to ask. And I will continue to ask and be kind of annoying about asking, because we have great technology and we need to make sure that that technology has maximal benefit within society. So we'll go back to the very beginning. That's why I'm a sociologist. And I like asking those big questions because maybe we get to the opportunity to find good solutions. And I don't think we're ever going to have that mega solution, but solutions in little pockets of places that we can then translate and make improvements that are sustainable and translatable in other spaces, that matters. So, keep doing that work. It's important to me.
Agreed. Now it's time for the lightning round.
Okay, I'm excited.
Wonderful. So my first question for you is, what do you think is maybe the most underrated factor in high-performing healthcare teams?
Trust.
Can you speak on that?
If teams trust that they are can say things in a safe space, they have psychological safety, that their voice matters, and that they trust that their peers are also well-intentioned and share that same ethos toward mission and drive and patient outcomes, I think we have probably setting ourselves up to have a really high-performing team. Where we have trust, folks have voice. And so equipping, and this is it sounds simple, but it's so important. That one person who might see a potential medical error about to happen, but they don't feel confident to raise it, or they don't feel confident enough in their position to be able to raise that and question what an authority is doing. That's the intersection that's so critical of trust and voice, because both are needed for a high-performing team.
What do you think is the biggest barrier to human-centered healthcare, not only today, but in the future?
Human-centered. So human-centered sounds to me like we're talking like from looking at a big macro view. First off, as humans, we don't always make the best decisions. That's hard. I don't make the best decisions. But what's the biggest barrier? I would say lack of agency, and I'm not trying to bring this complex concept in right now, but this lack of being able to own one's path in every direction. So if one doesn't have access, or if a group of folks don't have access, it's really hard to overcome that individually. And so how do we as a society help folks overcome that, I think, is the biggest barrier.
And my last question for you is, what is some of the best advice that you've ever received?
Okay, so this one was hard for me because I'm a perfectionist. I may not look like it, but I am. I will write and rewrite and rate and rewrite. And I had someone tell me that I need to learn how to ship. I need to learn how to ship. Know what you're doing, but ship. And I have tried to apply that in spaces where it's appropriate to do so, and it's improved my productivity. So I'm a late bloomer to that concept, but it's been incredibly impactful for me. So just ship. Great ideas are amazing, cannot stay in your head, and they cannot stay in your notebook.
Well, Caroline, thank you for your thoughts today on everything that we discussed. Maybe what are some final things that you want to note for the audience?
I would love folks to look at Table Talk on Health, reach out if anyone would like to share their perspective, their thoughts. I'd love others' thoughts on how we can even improve the work that we're doing. And then I guess another thought would be continuing education is critical, and it's not just critical for healthcare professionals. Whoever's listening to this, whatever you're doing, stay in that lane of wanting to be curious and learning throughout your journey as a professional or your journey as a human, because education and learning and sharing ideas helps us all grow, particularly if we do it with others.
Well, again, thank you for your time. Where can people choose to engage with you if they choose to do so?
Absolutely. So I would say go to Table Talk on Health. And we have a website, and there you can engage with, you can enter some information to become a follower of the site. I also have a LinkedIn profile under that, and reach out. Would love to hear more about what others are thinking.
Beautiful. Well, Caroline, thank you again for your time on the K in Clarity podcast.
Thank you. Thank you.